It is now my privilege to introduce our first speaker and moderator, Steve Feinstein, MD, FACC, FESC, cardiologist, co-president of ICUS, Chicago, Illinois. Dr. Feinstein.
Thank you very much, Matt. Welcome, everybody. It's an absolute pleasure to present with this group of colleagues, friends, wonderful scientists, and just good people. So our topic is microbubbles in therapy. This is a free education webinar presented by ICUS in full coordination with Northwest Imaging Forums. So I want to welcome you along with Stephanie Wilson, co-president of ICUS. We really appreciate everyone's interest in this. And as you see, we have an exceptional faculty, and Northwest Imaging provides exclusive CME, and including our friends in Telios and AR DMS for ongoing collaboration. As you will see, I will ask you to join ICUS multiple times in this introduction. Here's our website. And if you want to connect on the mobile app, go to ICUS Connect, and you will be connected. So what is ICUS? We're growing. We're now in 85 countries, and we're growing. Anybody is welcome, and everybody is welcome, no matter what your interest is in science or bubbles. We believe that contrast ultrasound is essential for modern ultrasound labs, for clinical safety, for research. It's patient-friendly, cost-effective, and it produces very clear, high-resolution images, changes therapies. It's wonderful for whole body imaging, tumor perfusion, and often will be shown to reduce downstream testing. That is, you can do tests at bedside, not needing other modalities that will delay treatment and time. So again, one of the many times I'll mention, no charge for ICUS. Please join us. A QR code is listed there. Everything is free. CME, mobile apps, and news monitors. It's for everybody. Let's jump a bit. So we've really been stressing sort of optimizing bubbles and machine. We've done beautiful presentations, very well attended. We have the liver and kidney coming up in December, and this will be demonstrations. Please make a note. The 40th Annual Bubble Conference is October 1 and 2. It'll be at the Drake Hotel in Chicago. Here's our website. Again, please visit that and plan to attend. Go to the website on your mobile or on your desktop. It's filled with numerous presentations. They're all free. We archive this seminar plus others. Again, this is join. Thank you. We do come out with a news monitor on a regular basis, put together by Robin Adams at ICUS. And this has been a major effort for the last few years. Sonographer Training Resource Hub. We do have modules to train sonographers, to start IVs, to inject contrast, just like every other modality. So this has been very important to us, and I think we've made great progress. As you can see, part one was IV training, and then hands-on IV, and then certification. That's all built in, and we are very active with the sonographer teaching schools around the country as well. Again, so let us also say that we are greatly appreciative of all sponsors. Their support of ICUS allows us to go on. It's a volunteer grassroots organization. Nobody makes a salary. We don't have brick and mortar. So thank you at the diamond level, Bracco, Platinum, GE Healthcare, Gold, Lantheus, Silver, Canon, Siemens, and Sonoscape, and Bronze is Denton, Fat Roman Studios, Northwest Imaging. Thank you very much. Let me stop there and transition into the, it's great to be with our friends here online. So I'm going to talk about gene therapies and what's bubble and what's gene got to do with each other. There's probably nobody in the audience who knows who's driving that truck. That's an old cartoon character called Mr. Magoo, who had very bad vision. People made fun of him, but somehow he got to the mission. Always at the end of the story, he succeeded. So I am not saying I'm Mr. Magoo or anyone else is, and my headlight is an ultrasound beam. But the analogy here is this is a truck, and we are driving with ultrasound, and in the back or the payload are microbubbles with DNA, and we will drop them anywhere you want at any time. I have no conflicts. let's begin this. So on this slide, it's sitting in a psychiatrist's office, and it's DNA. Says, okay, let's go back to your childhood. So my outline is going to be what's gene therapy, therapeutic approaches, what's COVID got to do with gene therapy, therapeutic designs, and delivery systems. So what is gene therapy? Well, it's defined here by the FDA and the EMA. They're pretty similar. Basically, objects or products that mediate their effects by transcription or translation, so covering DNA and RNA, and that they insert sometimes or not insert. So they can be episomal or insertional. So the EMA is very similar. So let's just look. What's going on with the human genome? Well, it was completed project, the Human Genome Project, in April 2003. Now, it's 22 years ago. There's 46 human chromosomes, 3 billion base pairs, 25,000 protein codings. So that gives you a sense of how much and how broad our approach to therapy can be with gene therapy. We understand less than 5%. Most genetic diseases are a single gene in most cases, sometimes more than one, but this leads to what we call monogenic diseases. And according to the genetic and rare diseases, dysfunctional genes account for 80% of the 7,000 diseases. 30 million people in the US, 300 worldwide, and sadly, half are kids. So according to the Center for Advancing Translational Science, 500 human diseases are treatable. That's not very good. Gene therapy, in vivo. We're going to talk about in vivo. We will not discuss ex vivo. Ex vivo tends to be hematopoietic cells and CAR therapy, CRT. We're going to talk about in vivo. That is directly injecting genes into the body via any of several mechanisms. And when we say DNA, it generally includes DNA, RNAs, ASOs, etc. So what's the approach? And I'm sure you've all heard this. How about gain of function, loss of function? This is not a political statement. This is just, these are the approaches. So gene augmentation, you have loss of a function. Well, put a functional gene in and make it work. And if you have gain of function, which you don't want, suppress it. Oh yeah, let's read through every one of these. No. Look, here's what's interesting. This goes back 22 years. Say, wow, that's a lot of, is it? In 22 years, this is the number of gene therapies we have. And why don't we look at each year? It's not a very impressive list, though we've been doing gene therapy for 30 years. We'll get to a little bit why this list isn't thousands long. All right. So I thought we were past COVID. So I would like to introduce you to the concept that many of us have had COVID vaccines. We are now part of the gene therapy revolution. What's that mean? Well, vaccine therapy is usually an acute treatment with a resulting protein, such as an S or a S spike protein produced, and you get an immune response and everyone's happy. Chronic gene therapy is not that way. You are trying to, insert genes into the genome or an episomal place that will be permanent. So very different. So when COVID came out, Pfizer made and Moderna made vaccines that were revolutionary. Lipid nanoparticles and RNA-based therapies. That is, when you inject an RNA, it doesn't go to the nucleus, it goes to the cytoplasm, makes its protein, S protein, and we are successfully defending ourselves to some degree against COVID. This is remarkable. I think, was it Mark Mulligan said, first time in history we've had an mRNA vaccine. Is this gene therapy? I think people don't want to say that, but I found this headline, American Society of Gene Therapy, biggest organization, COVID vaccine can show gene therapy is a viable strategy. I think if you say that to people, it might be taken the wrong way. Okay. So let's talk about what we're going to treat now with cellular disorders. So our treatments today are not very good. Let's just summarize and say that. Okay. Clinical trials, yes, growing nicely. If you look at in vivo, which is the cumulative, and ex vivo, which is CAR T, you can see that ex vivo is dominant. In vivo, it's got some ways to go. So what is gene therapy? What are the components? A vector, could be an adeno-associated virus, AAV, or its helper viruses tucked underneath, which would be adeno-retrolentin promoter. In there, we have tissue-specific promoters that will go to an organ system and a cell type. What's the transgene? It's the payload. Here's the little known thing. There's a problem with some of this stuff. It's called delivery systems. So you can go two ways: viral, such as AAVs with helper viruses or adenoviruses, but the non-viral mediated agents are what I'm going to focus on: lipid nanoparticles, GalNAc, microbubbles, hydronanotherapy, gene guns, and so on. So that brings us home. Delivery, delivery, delivery. The major defect in gene therapies for 30 years is how do you deliver your product, your payload, to a specific target and not do off target? How do you do that? It's not known. If you inject naked DNA in the blood, it's quickly metabolized and doesn't really hit the target. And so you need to come up with a delivery system that will drive you right to the tissue you want. So what's the ideal system? Something that can take big payloads and deliver it where you want, high efficiency. You can do it serially, long-term stable expression, no insertion into the genome if you can help it. And you want to hit cells that are mitotic as well as post-mitotic, no immune reactions, and scalable. It's got to be big time. All right, so again, just sorting them out. On the left is what the world is made of today for gene therapy. It's viral mediated by and large. Non-viral is dominated today by lipid nanoparticles, GalNAc. Sonoperation's raising its head. So let's take a look. What are our delivery options? Well, as I've mentioned repeatedly now, but look at the defects. Nuclear payloads are quite limited. 5 kilobase pair is not a very big gene. Lipid nanoparticles, nice. Your vaccines were that. They go everywhere in your body. They can be a little bit toxic or allergic effects. They can take big payloads. GalNAc, specific right to the liver, it's a very effective tool. And the bottom, microbubbles, the best, of course. Site-specific, serial injections, no toxicity, big payloads are capable, and we can go to any organ. So how do we do that? Well, intravenously or other methods, but intravenously inject the bubbles plus DNA, place your ultrasound beam over the target, such as the liver, inject your DNA out of the bloodstream into the cytoplasm. It will find its way to the nucleus. It undergoes transcription. The transcription goes to translation, and you get your protein in the ribosomes and back into the serum. So that's the sequence for bubble gene therapy. For those who aren't familiar with bubbles, they're small acoustic microspheres. They're not bubbles. They all have shells. They vary on their concentrations. They're quite safe. They've been FDA approved for decades now. The half-life is anywhere from 3 to 10 minutes. Here's a little video showing what happens, but let's start with step one. Inject the bubbles with their nucleic payloads. Turn on the ultrasound. As you can see, rupture the bubbles and deliver the payloads to the target. This is a video image of an in vitro system by Alfred Yu. It is one example of probably 7 or 8 sonoporation issues that are going simultaneous. This is called acoustic cavitation. You can see transient opening of the cell membrane and sealing. So this is one of many mechanisms going on simultaneously with sonoporation. It's not the only. Can we scale this up from an in vitro single cell? Yes. And the whole list of speakers after this will show us how this can be done in various target systems. And just as a primer in sonoporation, you can go from quite low energy to higher energy, which will cause disruption. And as you can see down on the bottom cartoon, we are able to penetrate the endothelial border, which allows us to get in the interstitium and the cytoplasm. This is a really pretty video of a micro bubble or acoustic microsphere undergoing stable vibrational cavitation in intravital microscopy of a capillary. This, I think, is the secret sauce. All right, again, On the left on the grain, you see this is a single cell. It has a skeleton just as you do. It's an endoskeleton. So without it, you would be an amoeba, so would this cell. Immediately after rupture in the second picture to the right, there's been a pore created. Immediately after that, the actin fiber skeletons actually transiently are dismissed. Opens the pathway for the DNA or payload, which is entering the cell, to go directly to the nucleus. This process is unique to sonoporation and does not incorporate cytoplasmic sequestration, which is identical to AAV. So very, very different. And lastly, I was lucky to work with this whole crew of people. We wanted to raise HDL, cholesterol, because that's supposed to stop atherosclerosis, may even be good for Alzheimer's. So what we did is we injected somewhere around rat tails. We input the ultrasound probe over the liver, and we at first use a reporter gene called EGFP, or green fluorescent protein. So you can see in the number one, we took a native liver, and after a 1-minute treatment, turned the liver green. The second thing, let's get into a gene that is therapeutic. So we put in the human ApoA1 plasmid into rats and used the same sonoporation, and we went through transcription. So we went from DNA to RNA polymerase. That then created RNA, goes out to the cytoplasm, and it made human ApoA1 in the rat, as you can see. In the third level, we then injected the same process, and we determined what level of ApoA1 was circulating. The most fascinating thing is the red is actually mislabeled on the slide. It's actually, well, it's correct here. It's the control. And HDL therapy is the acute phase reactant. People have heart attacks, the HDL drops up to a third and can be for a month. Of course, we did controls here, so the red is control, and they have, the rats had acute phase reactants, the HDL drops, but our blue was our treatment group. So we exceeded the drop by adding new non-homologous HDL, and it was effective. On the far right is rabbits, and you can see the treatment going up, but we had two controls, and you can see it drops considerably because that's acute phase reactant. And rabbits, it dropped 50% at day 3. So to conclude, the future of non-viral mediated gene therapy is highly promising. It's non-invasive, capacity for serial dosing, oversized payloads, minimal risk, and no evidence of immunogenicity or oncogenesis. Thank you all very much.
Thank you so much, Dr. Feinstein. Now I'd like to introduce our next speaker, Wilson Matthias, Jr., MD, FACC, Associate Professor, University of Sao Paulo, Medical School Director, Echocardiography Lab, Heart Institute, Board Member ICUS, Sao Paulo, Brazil. Dr. Matthias.
Thank you very much. It's a privilege and honor to be here speaking to you. We are going to speak a little bit on sonothrombolysis, a work we have been doing for almost 10 years here in Brazil. I have no conflict of interest for this presentation. So the topic of my presentation regards to a disease that is responsible for actually 32% of all of the death worldwide. Half of it is coronary artery disease. And echocardiography has been a wonderful tool to study this disease. Since 1953, when echo was born with the mode A mode, all the way up to all the technologies, TE, color flow, Doppler, 3D echo, strain, and myocardial perfusion echocardiography, which showed us a new window to the microcirculation. So these bubbles, as you know, are very small, about 2 microns, and they react, they oscillate while exposed to ultrasound. And depending on the ultrasound energy, you may have just a regular oscillation or bubble rupture, which is used for the topic I'm going to be speaking about that is sonothrombolysis. These bubbles have been the transpulmonary microbubbles that allows for this therapy has been described long ago. In 1984, Dr. Feinstein described for the first time the myocardial perfusion studies together with Roberto Lang, allowing us to see the microcirculation. So all of the knowledge we had first was in regard to the study of microcirculation. These bubbles were used in 1993 by Dr. Hiroshi Ito to describe for the first time the no reflow phenomena. Dr. Ito demonstrated that despite the recanalization of acutely occluded left anterior descending coronary artery, in despite the recanalization, the myocardium in some instances may not recover. And that is the cause of it is there are several factors that cause it, but one of these factors is in regard to the migration of microthrombi, and that results when it happens in a very significant worsening of the ventricular function and the prognosis. In our lab, we have been studying the myocardial perfusion in several settings. This is just an experimental study in the setting of acute myocardial infarction. Dr. Paulo Magno worked with us and studied several dogs in order to demonstrate if this technique was good to measure the size of myocardial infarction. In this experimental study, he demonstrated that it was quite good with a very good correlation with the anatomic specimen. And this is just a clinical case demonstrating the utility in an acute coronary setting that we see every day when we are doing sonothrombolysis here at INCOR. This is a patient with chest pain with a non-diagnostic EKG. Apparently, left ventricular function is normal. And when you inject bubbles, you clearly see that, which was not seen by just 2D echo, that there is a lack of perfusion in the anteroapical wall and also a wall motion abnormality that was not observed without ultrasound enhancing agent. This is just the two-chamber view, the same situation. We can't see well the wall motion abnormality, but when we inject the bubble, you see the lack of perfusion and the extensive anterior wall motion abnormality. So it's a very important diagnostic tool in the setting of acute myocardial infarction. So this is quite important because with the use of these bubbles, we end up changing about 35% of the therapy we decide for a particular patient. And there is taking advantage of these characteristics of these microbubbles, we can improve our imaging using for border delineation, for microcirculation assessment, in order to demonstrate if there is an occluded coronary artery, and also for therapy. And in the context of acute coronary syndromes, there are a lot of significant drawbacks in the treatment of this acute ST elevation myocardial infarction. The first of it is that fibrinolytics are effective in about 6% of patients. And if they receive it up to 4 hours of the initiation of chest pain, we may have around 10% of significant hemorrhagic events, and especially in developing countries like Brazil, most recanalization therapies are still not available for a significant part of the population. So there is a lot of room for improvement. This is the case of a patient that he was arrived at the hospital before 2 hours of chest pain, had his left circumflex coronary artery opened immediately, but despite of the stent implantation, you could see clearly that there is this dark area that corresponds to a no reflow, extensive no reflow area in the area of the left circumflex coronary artery, demonstrating that despite the optimal treatment that was offered to this patient, he was still getting a little benefit from this therapy because of this complication that may end up occurring in about 40% of the cases. So the mechanism of sonothrombolysis is complex, but maybe the local thrombi mechanism would be microjetting in thrombi rupture, allowing the recanalization of coronary artery. So an experimental study from Dr. Tsutsui that worked with Thomas Porter at the University of Nebraska and works here in São Paulo with us. She studied 12 dogs, and this study that was published in 2006 inspired our human study. She studied 12 dogs and applied intermittently high mechanical index ultrasound in this thrombi-occluded bypass. At first, she imaged the bypass, demonstrating that there was just a small channel passing through the thrombi. And then after several intermittent impulses of high MI ultrasound, she observed that these small channels increased in size and ultimately ended up opening the graft after 90 minutes. In that regard, using this background, we designed our first human study in ST elevation patients with acute myocardial infarction here at the Heart Institute in São Paulo, Brazil. This study had a support from a Brazilian NIH agency, University of Nebraska, and also the Microvascular Therapeutics and Lantus Medical Imaging. During the study period, from 2014 to 2018, 3,479 patients with acute MI came to our hospital. 1,622 had no STEMI and were excluded. Out of those, also, there were 1,554 patients that underwent pharmacological fibrinolysis that were also excluded because we only wanted to study prime ST elevation acute MI. Among other exclusion criteria, we ended up with 303 STEMI patients. 100 of them arrived during weekdays at the commercial time period, and they were randomized. 50 patients for what we call the therapy group, that was the standard therapy, primary PCI and sonothrombolysis, and what we call control group, which was the standard therapy of PCI only. Also, we saw 203 patients that arrived at night and on weekends, and we followed them in order to look at their rate of spontaneous coronary patency. There were several measurements that were made in these studies regarding to the status of cardiac function. We performed a cardiac MRI at 72 hours in order to demonstrate the size of myocardial infarction. And also left ventricular volumes and ejection fraction were measured by echocardiography. The MRIs were all performed, were all read blindly, and also the echo, but the MRIs were read at the University of Nebraska in a blinded fashion. Well, first, one thing that everybody was worried about was if the therapy was going to cause a door to balloon time increase, because we approached those patients as soon as they arrived at the emergency room, and we performed some thrombolysis while they were being prepared for the catheterization procedure. So there was no difference in door to balloon time between controls and therapy group. Regarding the coronary artery patency, in the first coronary injection, we demonstrated 48% in coronary patency for the therapy group, and about 20% in the control group and the reference group, that were those patients that arrived at night and on weekends. This is a case of a 52-year-old male, hypertensive, with dyslipidemia, that had a continuous chest pain, a very strong one, and 1 hour and 45 minutes before, that started 1 hour and 45 minutes before he arrived at the ER. And this, on the left, you can see the extensive area of wall motion abnormality and lack of perfusion. His ejection fraction at the time was 29%, and on the top left, you can see the EKG. 12 minutes after sonothrombolysis, still in the ER, we could document a decrease in ST elevation, the V1, V2, and V3. And interestingly, the wall motion abnormality was still there because of myocardial stunning, but you could see that the microcirculation was almost completely filled, demonstrating the coronary artery was opened at that point. And this was after PCI. You could see a complete recovery of the ventricular microcirculation, despite still the presence of significant wall motion abnormality. This patient had a very small size of myocardial infarction that is demonstrated in this MRI, especially in this short axis view at 12 o'clock. And also, his left ventricular function is improved significantly. If you look at the longitudinal strain for this patient, immediately after PCI was 10%. 72 hours later, it was 11.2, and 6 months later was 15.5%. When looking at the data on improvement of left ventricular function, we could see that patients that fell into the therapy group had a smaller size of myocardial infarction, 29 grams, instead of 40 for the control group. And the ejection fraction improved in both groups, but improved more significantly in red in the therapy group, as well as the strain. You could see that longitudinal strain was much higher in the therapy group. At 6 months, it was 17% versus 13.6%. And we also analyzed other parameters of cardiac function. We could see that the left ventricular volume also decreased in patients that fell into the therapy group, and the left atrial strain improved as well in patients that fell into the therapy group all the way up to the 6th month. We are now, that trial was closed. We are now doing a phase 3 clinical trial. At first, we planned to do together as a multi-center trial in Brazil, US, and Netherlands. But because of the pandemic, things got a little bit disorganized, and some centers took a long time to start. So we ended up each center doing his own study. We are carrying out in Brazil this trial, and we expect to enroll 340 patients. Currently, we have 243 patients already enrolled in several subsets of acute coronary syndromes. With the sub-study 1 studies patients with ST elevation. The sub-study 2 is an interesting group. I'm very interested in this group because we are looking at patients below 12 hours of chest pain that underwent lytic therapy as a primary treatment. The sub-study number 3 are patients. It's a study that's similar to what Tom Porter and Otto Kemper are doing as well, Otto in the Netherlands and Tom in the US. It's a subset of patients. We are looking at anterior acute MI, ST elevation, and we are doing sonothrombolysis only after PCI. And the sub-study number 4 enrolls patients with no-ST elevation MI and also unstable angina. We don't have data right now we are still not analyzing it, but maybe by the next Bubble conference, we will finalize at least few of these groups. We are almost at the end of the sub-study number 2. So one thing also we did in partnership with our engineering school was an equipment with a non-imaging equipment called sonothrombi that resembled the same characteristics of ultrasound that we deliver intermittently using the echocardiographic machine. But this system this is obviously a prototype, and it's intended to be used in ambulance. So it's a non-imaging system that has just a single button for the nurse to push it, glue the transducer on the chest, and inject the bubble while the patient is being transferred to the hospital. So this is one thing that we are very excited, and we are currently doing a partnership with a US company. These are some of the publications we have done during this time. One very interesting thing here is the last publication that I don't have the time to talk to you, but it was a successful recanalization of occlusion of a right pulmonary artery in a kid with congenital heart disease. She had a completely thrombosed right pulmonary artery, and we could recanalize it using sonothrombolysis associated with alteplase. So this is published in the Case Journal, and anyone that is interested in seeing and read the description of this case, I suggest it. It's very interesting. So that's what I had to talk to you. And as Sir Winston Churchill said during the Battle of Alamein, I think we are still in that situation. This is not the end. This is not even the beginning of the end, but perhaps this is the end of the beginning. So we are very excited about this, and I truly believe that this will be a very important form of therapy in acute coronary syndromes in the near future. Thank you very much for the opportunity to present it to you.
Thank you so much, Dr. Matthias. We'll now introduce our next faculty speaker, Kurvo Huninen, PhD, University of Toronto. Dr. Huninen.
So I'm going to talk about blood-brain barrier opening with focused ultrasound, and thank you so much for inviting me to speak. I have disclosures. I'm an inventor on patented technology, and but no other conclusion about that. So here is a blood-brain barrier. Blood-brain barrier is a special characteristic of vessels in the brain, and where endothelial cells are tied together very, very tightly, so that there are very few molecules that can leak into the brain itself. So it's unlike other tissues. And in addition to the physical barrier, there is also basement membrane, which is another physical barrier, and then physiological barrier. So if foreign molecules enter in the brain, they are actively pumped back to the bloodstream. So there is very difficult to get any kind of therapeutics into the brain. It's estimated about 98% of potential molecules that could be beneficial do not enter in the brain. So there is a great need of technique that would allow us to get medications into the brain. So the idea was maybe we can use image-guided focus ultrasound and focus the ultrasound beam to the brain and shake the endothelial cells a little bit and allow them to pass the therapeutic molecules inside the brain. And that was the idea. And it turns out that it's after many years of trying, that the bubbles are the secret. So when we sonicate the microbubbles in the bloodstream, they expand and contract, and they are about the size of the capillaries, and they stretch the endothelial cells and open the gaps between them. And in addition, they also add some active transport across the blood-brain barrier. And it turns out that they inhibit the efflux pumps, so they allow the drugs to stay in the brain. And it turns out that the sonications are very small. In the first experiments, we have 10 millisecond sonication once a second with very low time average power. So now the skull bone heating is not an issue, so we can easily sonicate the brain. And it turns out that we can get nicely molecules inside the brain and without any histological or physiological evidence of tissue damage. And with the MRI, we started these experiments, the MRI controlling and guidance. And with MRI, you can easily see the contrast enhancement. So in other areas of brain, the contrast agent stays in the vasculature, and where you have sonicated, you can see nicely the enhancement when your pressure amplitude is high enough to do that. And this heals itself quite quickly, and in our hands, about 6 hours is restored to the normal value. And here you can see now the percentage of sonicate locations that had blood-brain barrier opening as a function of the pressure amplitude. And you can see that there is small value of pressure amplitudes here where there is blood-brain barrier opening without any damage. But if you go too high, then you get necrosis and other sorts of damages inside the brain. So this needs to be controlled precisely. And so in an MRI, you can see when it's open. And then if you sonicate at the higher pressure amplitude values, you can see these black spots coming in T2 starved images. And these indicate that there is an extravasation of red blood cells in the perivascular space. So this is something that clears itself in a few days. It's not too dangerous. It doesn't cause brain damage, but we feel the upper limit. So with the MRI, you can kind of tailor your exposures between these two values and have the blood-brain barrier opening, but no damage to the brain itself. And that's how it is kind of used in the clinical practice. In addition, there are acoustic waves of controlling, but we talk about that a little bit later. So there have been over 600 publications that have explored different therapeutics delivered through the blood-brain barrier. And you can see it's a full range going all the way to the cells. So practically anything that you try can get into the brain. And these therapeutics have been shown to be effective in treating animals which are disease models. For example, brain tumors have been effectively treated with chemotherapy that has been enhanced by focused ultrasound and by microbubbles. And there are many other diseases. So this is kind of what we do. We have MR-guided large 1,000-element phased array device that is MRI-guided. There are other devices also that are either implanted inside the skull bone or that are navigation-guided. Multiple companies are involved in this kind of device development. So here is the very first experiment that performed in a patient, very first clinical trial. So we sonicate 9 locations, and you can see nicely how those locations have the blood-brain barrier opening very, very precisely. And that was exactly 10 years ago that we did it here at Sunnybrook. The publication came later, but it demonstrated it works as well in animals as in humans. And I'd just like to highlight just a couple of the studies. There are about 15 to 20 clinical trials that have published results. So here is a study where we sonicated breast metastasis in a brain. This is HER2 positive breast met. And here you can see a couple enhanced signals, and here you can see the enhancement in the tumor. And so we get about 450% increase in the drug concentration. So these are antibody molecules, so large molecules, and they were radio labeled, so we could see them in the SPECT scanning. And then in the same study, we also looked what happens to the tumors, and you can see that after multiple treatments, you start seeing this black area in the middle of the tumor. It's growing, and then the tumor starts shrinking. Unfortunately, in this study, we had only 4 patients. Now we are continuing that study, trying to get enough numbers to look effects on the actual tumor treatments. So the other area that we are looking into is Alzheimer's disease. And why do we look into Alzheimer's disease? It's the most common dementia in patients. 1 out of 10 people over 65 has Alzheimer's disease, and the number increases 1 out of 4 of 85-year-olds. And these days, people live longer because cardiac issues have been dealt with, and cancer treatments are better. So that is becoming more of an issue. And this is microscopically, there are plaques, these amyloid plaques and fibroid angles, and these are causing the brain cells to eventually die, and eventually patient dies. So these are just some of the symptoms in with disease. So it's a very, very important disease. And here you see how the theory is how this disease progresses. Is the first there is the buildup of this amyloid plaque, and then sometime later there is a neuronal damage, and then the symptoms finally followed with this. So the theory is that if you could remove those amyloid plaques, then we could potentially stop the progression of the disease. So we have been looking for many years now, almost 20 years, in how to treat this Alzheimer's disease, and first looking at Alzheimer's disease animals. And in the first study, we delivered antibodies, and here you can see this is unread site, and this is treated site, and you can see there are very fewer amyloid plaques inside the brain tissue, and here you can see it's quantified. And the next study, in this study, we noticed also that just the control exposure with ultrasound and microbubbles and opening the blood-brain barrier seemed to have an impact on the plaque load. And in the follow-up study, we increased the numbers, and true enough, it was able to reduce the plaque load. And then we did another follow-up study where we used normal mice and exposed them to blood-brain barrier opening with microbubbles. And we observed that there is increased neurogenesis, so generation of new neurons in the brain induced by this ultrasound-induced blood-brain barrier modulation. And then its final study, we looked again ultrasound opening along with microbubbles. We saw again a reduction in plaque load. This is Alzheimer's mice. We saw neurogenesis and surprisingly, memory improvement. The working memory of these animals were restored to the level of animals that didn't have the disease. So very encouraging results and very surprising. So indicating that there is some stimulatory effect that these focus ultrasound microbubbles, and it seemed to be correlated with the opening of the blood-brain barrier itself has a therapeutic impact and a neuromodulatory and stimulatory effect. So that's exciting thing. Which has been, we have explored it in patients, demonstrated it's safe to open the blood-brain barrier. And in the United States, West Virginia, they conducted a study where they sonicated and opened the blood-brain barrier in Alzheimer's patients, simultaneously injecting them with antibody. And here is the PET scan. So this is the area that they treated. And this is amyloid scan showing how much amyloid is in the brain. So this brain had lots of amyloid. And then this is 6 months later, the monthly treatments. This is the control site. So some reduction of amyloid, but this is the site where that was treated. And you can see a significant reduction in amyloid in this area. And here you can see actually in all the 3 patients how much faster the amyloid was cleared on those cases, those areas where that were sonicated. So that indicates that we could potentially enhance the treatment of antibody for Alzheimer's disease. Of course, this is treating part of the brain, so it doesn't allow you to see if we can stop the disease progression or if there is any behavioral improvements in this study, but future studies are planned to the whole brain and then see if we can translate this to a practical impact on patients. The other area that is looked at is that when we sonicate the blood and have bubbles in blood-brain barrier, the barrier is open. It's also open to the molecules from the brain to enter the bloodstream. And if you take blood sample, the hope is that maybe we can now diagnose what disease patient has in that image-specified locations, and then analyze those molecules and maybe have a diagnosis. And that has been shown in animals. And we have shown also in humans that if you look the amount of cell-free DNA in the bloodstream before and after sonication, that it is hugely increased. And there is now a multi-institutional study that is looking into this and seeing how much diagnostic value that has. The other study, going back to the tumor studies, is there is several papers have been published on glioblastoma treatments, and there is a study coming out, multi-institutional study in next 10 days or so that is looking at the survival benefit of this kind of treatment with chemotherapy. So where do we go in the future? So as I showed you results from MR-guided systems where you can see the blood-brain barrier opening in animals in relatively small volumes in most cases. It requires the MRI scanner, complex system, and fixation, and so forth. And the idea is that we need to go to a system where we don't need the MRI. It's much faster, and the blood-brain barrier opening is controlled by acoustic means. So because every time we sonicate, the bubbles vibrate, and we can pick that signal up if you have receivers. And this is our device that we have developed over the past few years. Again, still MR guided, but uses fully steerable phased arrays. Has 4,000 phased array elements that are electronically controlled, so they can quickly scan the focal spot around, and that way we can even open the blood-brain barrier and whole brain if you want to. And it has also inbuilt receivers that allow detection of the bubble vibrations inside the brain during the sonication. So allows very precise exposure control. And this is a video that we did with similar device looking into bubble activity inside a rabbit brain. So this is which we can capture these bubble images with very high rate. In this case, it was 10 millisecond sonication. So each of those sonications was 10 millisecond. But we can follow the bubble vibrations with like 500 or 100 kilohertz rate if you like. So we can get very precise idea what happens to the bubbles. So now we can each location, in this case, had its different pressure amplitude level. It was tailored to the vessels and bubbles in that location so that we can get uniform opening. And this system is now in the clinical testing. We have done close to 10 treatments so far, and looks very good. But the real idea is that we use this technology, but also use it to customize the helmet for each patient. So these modules are removable, and the plan is that we rapid prototype a helmet for fitting the patient's skull, and that way we can have a customized helmet that fits in the exact location. And these are just examples in animal where we were able to open the blood-brain barrier. This is the MRI image, and this is the acoustic image showing exact same location where the opening happened. And this is now going to human skull in this case, and sonicating a pig. And we can have so large volume openings here. So these are several hundred sonications, and you can see how uniform this opening and well controlled it is. So that's where we are. So like I said, that the timing is still bad because there are studies coming out, clinical studies in the near future. But in animal models, many people have shown that the therapy is effective to treat diseases, and that there is this neuromodulatory effect, the clear amyloid, the neurogenesis, and memory improvement. So it could be useful by itself. In patients, the therapy delivery has been shown safe and effective, so we can enhance the drug delivery, we can quantify that, we can increase it. And the treatment effectiveness is emerging. So I showed you the amyloid data, which indicates maybe effective, but there is new data coming that will show its effectiveness. And then we also showed you that about a three-dimensional bubble activity mapping is feasible and can be used to monitor and quantify the exposures. And that would be the way how the future will look like. And then finally, liquid biopsy is feasible in patients, and most likely will have significant therapeutic value in the future. So I'd like to thank everybody, and so my group and people who are supporting and collaborating with us. And of course, the clinicians here, and Neil Lipsman is the main neurosurgeon supporting us. And Dr. Meng is also very actively involved now in the new neurosurgeon with our group. Thank you so much for listening.
Thank you so much, Dr. Huninen. We'll now introduce our next speaker, Flemming Forsberg, PhD, Professor of Radiology, Director of Ultrasound Physics, Thomas Jefferson University, Philadelphia, Pennsylvania. Dr. Forsberg.
Thank you so much. I appreciate the introduction, and I obviously appreciate ICUS for inviting me to give this talk on the delivery of cancer drugs. Here is, nope, didn't change. Let's try that again. Interesting. Try this one. There we go. And here we have just a list of people I've been lucky enough to work with in connection with these projects to acknowledge their contribution. And here are my disclosures for those that like disclosures, as well as the main NIH grant that's funded the study I'll spend a little bit of time talking about. So again, what we're dealing with here is the idea that you can do microbubble fragmentation, as shown in this by now classic picture from Kathy Ferrara's group, showing the oscillation, compressions, and then fragmentation of the bubbles, releasing whatever is in the bubble, gas, or maybe a drug of some sort. So that gave rise to the idea of moving on to sonoporation, imaging bubbles, nanobubbles, or microbubbles, destroying them or making them oscillate so that you get weaknesses and microstreaming and jets like that. That could give the full destruction, could get shock waves and opening up so that the drug that's either in the bubbles or on the bubbles or floating at the same time as the bubbles will have a chance to get into the cancer and do its job. Now, there's a ton of animal work on this, hundreds of publications, but I'm going to focus on particularly the human studies because there are by now a limited number of human clinical trials underway. I'm actually going to focus mainly on pancreatic cancer. Pancreatic cancer is a terrible disease, but it's also one where patients absolutely desperately need help. There's about a 5-year survival rate nowadays around 5 to 12%, and 40 years ago it was 5%. So not much progress, unfortunately. And if you see it, even though it's only 3.3% of new cancers in the United States, it's the fourth leading cause of cancer death because the new cases and the mortality is almost identical. And main reason is that 50% of our patients present with metastasis. There's about 200 patients that have been studied with sonoporation in humans. There are also, just for the sake of completion, a small study with 11 patients in breast cancer and a study with 17 patients in colorectal liver mets, but I will focus on the studies in the pancreas specifically. So the first work on this came out of Haukeland Hospital in Bergen, where 10 subjects that either had locally advanced or metastatic pancreatic ductal adenocarcinoma carcinoma got infusions of Sonovy in this case, in small allocuts every 3.5 minutes, and then they imaged the pancreas with a holder here, so just the patient's breathing moved the tumor back and forth within the beam, and this was right after they received infusion of gemcitabine. So the idea was that the concentration of chemotherapy drug was high at this time, and if you could weaken and open up these tumor vessels, similar to the fantastic work that Dr. Noonan just showed in the brain, you could have more leakage of chemotherapy and therefore have more therapy. And indeed, in this small study, it worked much better than we had expected, to be honest. The patients tolerated more chemotherapy cycles, which is not so important, but most importantly is that the median survival time almost doubled from 8.9 months to 17.6 months. There were 5 of these 10 patients that showed primary tumor diameter decrease, and 2 of them were indeed offered surgery. And if you look at the overall survival, so this is the 10 patients with sonoporation and gemcitabine and Sonovy in blue, and in red you see the data from 63 historical controls, and there's a statistically significant improvement in overall survival, which was very, very encouraging. Results from then onwards have been a little bit more mixed. There was a Chinese trial of sonoporation that enrolled 82 patients at 2 hospitals in China. And here, the patients, similar to the Haukeland study, were randomized to either get standard of care chemotherapy or chemotherapy and Sonovy. So these patients got 6 injections of diluted Sonovy with ultrasound imaging. Almost a quarter of the patients received FOLFIRINOX, about 22%. Most of them got gemcitabine and nab-paclitaxel, and then there was a third of them that got nab-paclitaxel alone, combined with an experimental agent referred to as S1. So the chemotherapy application here is different from what we have in United States and the EU, because in our clinical practice, we would expect about 80% of the patients to get FOLFIRINOX, and gemcitabine and nab-paclitaxel would only be about 20%. Also interesting, somewhat strangely, while the gemcitabine, nab-paclitaxel, and the nab-paclitaxel group got their bubble infusion in the sun operation right after the injections of the nab-paclitaxel. So within an hour or two of the start of chemotherapy, the patients that received FOLFIRINOX did not get sun operation until 48 hours after start of chemotherapy, because they followed them all the way out where the home infusion of 5-FU had been completed. So it's very unlikely that any of the other 4 drugs in this cocktail would be around at that stage. And in spite of that, all the data together showed a statistically significant improvement in overall survival, a p-value of 0.037. These are still, in my personal opinion, somewhat strange results, given that a quarter of this data comes from FOLFIRINOX injections 48 hours after you gave the chemotherapy. It's difficult for me to understand how enough chemotherapy was present, let alone could leak out to end up contributing positively to this result. But these are the data as they were reported. So we've been involved in an American and EU trial of sun operation where we're looking to enroll 120 patients here at Jefferson in Philadelphia and at Haukeland Hospital in Norway. And then the patients would either get, as I mentioned previously, standard of care chemotherapy or chemotherapy with, in this case, sinusoid bubbles. And here you see a more traditional spread of how we would expect our patients to get chemotherapy. We only used the clinically adopted cocktails, so either FOLFIRINOX or the gemcitabine nab-paclitaxel setup. Enrollment just ended here 14 days ago. This was a imaging protocol that involved a modified Logid-10 scanner with a C16 probe. We did some baseline B mode color and power Doppler. Then we did shear wave elastography of the tumor to try and develop a monitoring tool. And once we initiated the infusion of sinusoid and watched the wash in, that is very difficult for me to say today, as you can tell. Then we did sun operation treatment augmentation for about 20 minutes, slowly sweeping back and forth through the tumor. And then the end of this study, once the treatment part was over, we did a quick subharmonic pressure estimation, SHAPE as we call it, where we calibrated our data on the tumor and took some measurements to try and get a feel for the interstitial fluid pressure and the pressure within the pancreatic cancer. The final enrollment of this study was 97 patients, but we did have 15 withdrawals for various reasons. Some of these patients, unfortunately, were so ill that they passed away before they even had a chance to start chemotherapy. Some of them moved treatment. Some of them changed their minds, and it being the United States that part of this was taking place in, then some of the patients had issues with insurance, which is a unique American problem. So here's an example case just to show you this about 3.5 centimeter tumor in the pancreas. And then we see here in contrast mode, and you can slowly see the bubbles start coming in. So these tumors are not very vascular. There is not a lot of flow in that, which is part of the reason why these tumors are so difficult to treat, and because they have a very dense stromal layer sitting around the tumor itself. Just to show you the calibration we do, so we go in and look at the change within the tumor, and the change in this case is of the subharmonic bubble signals. We show those as a function of time. When we increase our acoustic output power, we get a very characteristic curve where if you pick the steepest slope of this change is where the bubbles are most sensitive to pressure estimation. Given the overlap between tissue and bubble signals in this setup, we took images both with bubbles and without to do subtractions and work this out. But here is just a quick example to show you again, before we start the sonoporation, no bubbles are seen within the tumor. And then afterwards, even though it's not a lot, you can actively now see bubbles flow through. So we definitely know that we are opening up these vessels, which is encouraging in and of itself. Results right now is more mixed. If you see overall progression-free survival and overall survival, you see that the controls are a little bit higher. None of this is statistically significant. And what you need to bear in mind is that we only have about half the data at the moment. A lot of these patients are still being followed. So this is just a snapshot in time. And because it's so early on, these numbers change quite dramatically when we get a few more patients. And this involves both FOLFIRINOX, gemcitabine nab-paclitaxel, both stage 2 and 3, and the metastatic cases in stage 4. So it's a very heterogeneous patient population. Encouragingly, though, the one established tumor market, CA19-9, you can see that with sonoporation, we get almost a doubling in the percent drop in that, 60% versus 33%. Here, just the spread of that CA19-9 data. And then when you look at the progression-free survival here on your left and the overall survival on the right. So you really should not pay too much attention to the curves, but more to the numbers. It's half the patients have had progression and about a third have unfortunately passed away. If you split the data by tumor staging, you would expect patients to do better on the stage 2 and 3, and indeed they do, but you really should see that overall survival here, both for stage 4 and for the stage 2 and 3, are only now barely beginning to enter the stage of what you would expect them to be for standard chemotherapy. Essentially, what I'm telling you is the data you see here are for the patients that progressed quickly and passed away quickly. And we still have a large number of patients that are moving through the disease process, and we will see how that goes. But encouragingly, when you go by chemotherapy, what you see here is that for gemcitabine and nab-paclitaxel, there is about almost 4 weeks, almost 5 weeks, improvement in overall survival at this stage, which sort of matches nicely with the original results from Haukeland. So maybe this is the drug cocktail that works better, or we need to go back to the drawing board and find out better imaging parameters. Nicely, there were no adverse events related to sonoporation. The number of serious adverse events were the same in the control and the active group. There were no differences. What we have pulled out, though, which is intriguing, is the ability to monitor treatment outcomes. So we look both at the shape gradients in decibel and the shear wave in kilopascal. And to date, we have data from 21 subjects after the first, third, and fourth and last chemotherapy cycle. 8 of these were responders. They went on and progressed to surgery, thank goodness. But 13 were, as you would expect, non-responders. And what you get out of that, when you start looking at them, on your left, you see the shape pressure measurements with bubble. On the right, you see the shear wave. What you see intriguingly is that responders in green and non-responders do actually split. Somewhere between the third and the last chemotherapy cycle, you can see that there is a difference that's statistically significant between the responders and non-responders. What you can also see is that unlike a lot of other tumors, people that respond get a softer tumor. So you see here that, sorry, a harder tumor. My apologies. A harder tumor was what I tried to say. You can see here in the shear wave how they get higher. And you can see in the shape gradient, which has an inverse relationship to pressure, that they get harder as well, whereas the non-responders stay the same or get softer. And the reason for this is this stromal layer I referred to earlier. So as the chemotherapy get in and starts killing tumor cells, there's not any openings for the cells to seep out, so they don't get the drainage and the softness that you see, for example, in breast cancer and other things. Instead, the tumor cells turn fibrotic and the tumor turns harder. And if you look at this data on an individual basis, you can see both for shape and shear wave that there is some separation more nicely in the shear wave data. Currently an accuracy of 70% for shape and 90% for shear wave in predicting after the fourth chemotherapy cycle whether these patients will respond or not. So that's about 2 months into treatment, which is very encouraging. We have no tools today for doing that, so we are somewhat on target in that sense. So I try to run through sonoporation, in particular pancreatic cancer. I've focused on human trials, which currently do not involve bubbles that carry drug. They involve trials with clinical commercial bubbles and augmenting chemotherapy. I focused on pancreatic cancer because there are almost 200 subjects there, and results have been mixed to date. The trial that we are conducting, the most interesting result is that the Gem-Abraxane patients have an improvement of about 33 days, and that the CA 1990 levels respond much better in the active group. But it looks like we may have a new tool for monitoring treatment. So with that in mind, as they said in old Egypt, it's a wrap. Thank you very much for your attention, ladies and gentlemen.
Thank you so much, Dr. Forsberg. I would like to introduce our next faculty speaker, John Eisenbray, PhD, FAIUM, Associate Professor of Radiology, Thomas Jefferson University, Philadelphia, Pennsylvania. Dr. Eisenbray.
Thank you. Just trying to get there. Okay, wonderful. So my pleasure to wrap up this excellent session. I'm also at the Department of Radiology at Thomas Jefferson University, talking again about microbubble cavitation, but in this case, how it can be used to augment radiotherapy. Very briefly, these are my disclosures. So we've heard from some of the prior speakers how microbubble cavitation can augment blood flow. And what's been known for quite some time is that inertial microbubble cavitation or bubble destruction can actually result in reduced tumor vascularity. This has been known for almost 20 years now at this point. This is some work that was pioneered really by Sandy Siegel's group over at Penn, where he had this technique that he called antivascular therapy. And he was able to show that there was this very nice linear correlation by how long he treated these tumors. In this case, these were VX2 tumors with contrast ultrasound, and the reduction in overall vascularity when he was combining this with bubble destruction. So the group showed this was effective, and they were actually able to show that if they did this sequentially enough, you could actually inhibit tumor growth. But what has kind of caught our eye and has really kind of gotten a little bit more traction in terms of clinical translation is this idea of combining microbubble cavitation-initiated vascular disruption with radiotherapy. And a lot of this work was really pioneered by the group up in Toronto, led by Greg Zornada, where they were essentially able to optimize the different parameter spaces in terms of timing, acoustic parameters, and contrast agent doses across multiple different preclinical models, and show that when you combine microbubble cavitation prior to or immediately after radiotherapy, you get this very nice synergistic improvement in overall tumor response and actually animal survival as well. And the group was able to essentially show through a series of mechanistic studies that as you get this bubble cavitation, you get shear stresses on the endothelial walls, which leads to upregulation of ceramide. And ceramide is a very well-documented radiosensitizing molecule. So what's been really exciting in this field over the last 12 months or so is that we're starting to see publications come out on phase 1 and phase 2 clinical trials using bubbles to augment radiotherapy. This is some work that was published again by the University of Toronto group in PLOS Medicine using bubble cavitation in breast cancer radiotherapy. This was published in PLOS Medicine, and essentially what they were using is an MR-guided focused ultrasound platform, which is shown here in the top left of this figure. They would then do treatment planning where they're essentially raster scanning across the area of interest, and then they'll do this in combination with ultrasound contrast, in this case, the contrast agent affinity. So they'll initiate microbubble cavitation across the tumor, and then from there, the patient goes on to their normal, in this case, external beam radiation therapy. So this was in the published study, they focused on patients with relatively advanced breast cancer. They assessed 25 patients for eligibility, were able to enroll 21 patients, two of whom were either discontinued or lost to follow-up. And that left them with safety and local recurrence analysis data on 18 patients and 3-month tumor response on 16 patients. And on the right, this is just kind of an example from the publication showing these tumors prior to and 1 month after this combination therapy of bubbles with radiation therapy. In terms of outcome data, it was very promising. So at 3 months, 18 tumors were evaluated, as I mentioned, 9 of which had a complete response, so 50%. 6 had partial response and 2 had stable disease, and only 1 patient in the entire patient population had progressive disease. And when you looked at 6, 12, and 24-month local control rates, these were 94%, 88%, and 76% respectively. So really phenomenal local recurrence rates considering the state of this disease. Very similar study published by the same group. This was in radiotherapy oncology. Only now they were focusing on microbubble cavitation in head and neck cancer. Again, this was a phase 1 trial. Head and neck cancer with radiotherapy becomes a little bit difficult in terms of a study design because there's lots of different fractionations out there. So some patients will get 5 fractions, some will get 10, and some will get 35 fractions. But essentially, the group was taking all comers with locally advanced head and neck cancer and adding these MR-guided focused ultrasound microbubble treatments, which are shown here in the red arrows, at different time points across the fractionation schedule. They assessed 14 patients for eligibility, 12 got intervention, and 1 was lost or discontinued their therapy during intervention. So this left them with safety and local control analysis in 11 patients and 3-month response on 8 patients. And very similar to what they were able to show in the breast cancer phase 1, no systemic toxicity from the MR-guided focused ultrasound bubble-related adverse events, no radiation necrosis or grade 4 or 5 toxicities were reported. And in the 8 patients that had at least 3-month tumor response assessment, 4 had partial response, 3 had complete response, and 1 had progressive disease. So again, similar to the prior trial, very impressive overall response rates in these phase 1 studies that also showed very good tolerability. Our group at Jefferson is very interested in liver cancer. We are a big liver cancer and chronic liver disease center. So we were interested in, can this technique be applied to HCC in particular? So one of our students at the time, Anne-Marie Descher, spent quite a bit of time looking at combining ultrasound-triggered microbubble destruction, which is shown in red, with radiotherapy, which is shown in blue. And you can see that in this orthotopic rot model, we get very nice improvement when you combine these 2 therapies in terms of not only tumor volume control, but also animal survival as well. So statistically significant improvements in overall tumor control and animal survival. And at the time, we spent considerable time and resources looking at safety as well, looking specifically at liver function, because of course it's not really sufficient if you're able to cure these tumors, but at the same time wreck the patient's liver. And what we were able to show is that there was no differences in ALT or bilirubin between either of these 2 animal groups that received radiotherapy, which was very important because it allowed us to take that safety data, go to the United States Food and Drug Administration, and get approval to do a phase 2 clinical trial combining ultrasound-triggered microbubble destruction and radiation therapy in HCC. For those of you not familiar with HCC radiation treatments, traditionally this is done using a technique called transarterial radioembolization. This is a technique where interventional radiologists will get access to the arterial blood supply of the tumor via a catheter, and they'll deposit these relatively large glass beads containing the isotope Y90. The Y90 is relatively high doses, at least 130 gray, and it provides a therapeutic benefit in roughly 25 to 60% of patients, 25 to 60% of patients when you use standardized response evaluation systems. So it's a relatively long half-life, 64-hour beta emitter isotope, providing the sustained release of radiation within the tumor itself. This is the study design for NCT 03199274, recently completed and published about 2 months ago. We enrolled 104 patients who provided informed consent, and then they were randomized to receive either their Y90 or transarterial radioembolization alone, or Y90 combined with ultrasound-triggered microbubble destruction 1 to 4 hours post-treatment, 1 week post-treatment, and 2 weeks post-treatment. Ultrasound parameters are shown here on the bottom left. It was a 10-minute infusion of Optison using a commercially available scanner with flash replenishment sequences. So relatively low duty cycles, but high enough mechanical index during the flash sequences to generate microbubble destruction. Study outcomes are shown here on the bottom right. So in terms of safety, we looked at physiologic monitoring, adverse events, and liver function testing 1 month post-treatment. And then in terms of efficacy, we had 2 blinded radiologists provide EMRISIST reads, and then also track time to required next treatment and overall survival. Here's a quick example case. So this is a patient who's on generally 6-month interval screening for HCC, comes in, has their MRI, and you can see that they have this 4 centimeter HCC showing up in segment 7. From there, they get referred to interventional radiology, who will essentially do a flow study to map out and perform dosimetry calculations for the arterial blood supply of the tumor. And then after that, using that same catheter-based approach, they'll either have technetium-99 as a radiotracer performed, or when they come back a couple weeks later, the Y90 isotope. So that's a long morning for the patient, but at most centers, the patient is observed for 3 to 4 hours before being discharged home. And that gives us a very nice window to do that first ultrasound exam. So this is the same case I showed you, B-mode ultrasound showing you this 4-centimeter HCC again in segment 7. This is about 2 hours post-radioembolization in this case. And this is the patient's first contrast ultrasound exam. So again, this is a 10-minute infusion of ultrasound contrast. And what we're essentially doing is we're watching the microbubbles reperfuse back into the tumor at a relatively low mechanical index. And then once we reach kind of full perfusion, we generate this higher mechanical index pulse to locally destroy the microbubbles within that vasculature. So the hope is, again, that we're destroying these microbubbles, we're generating inertial cavitation, we're temporarily injuring that vasculature within the tumor, and we're making the tumor more sensitive to radiation. We do this at the tumor midline for 4 to 5 cycles at the very beginning of the infusion for imaging purposes, and then we spend the duration of that residual 10 minutes sweeping back and forth and maximizing the number of bubbles that are being destroyed throughout the tumor. Same patient 1 week post tear. So now we're starting to see some treatment effects. You can see in that tumor that we have some nice kind of big black holes. Those are avascular areas. They're completely dead tissue. But of course, you can see that there's still quite a bit of vascularity within that tumor. So there's still tumor to be kind of eradicated. Good news for the patient, though, is, of course, that there's still therapeutic levels of radiation present within the tumor. And the hope is that combining these microbubbles and microbubble cavitation with that radiation, we're going to further sensitize that residual tumor to the radiation as well. Last exam for this patient, this is 2 weeks post-tear. Now you can see that we have a much larger, nice avascular area where that tumor was. Maybe a little bit of nodular peripheral enhancement, particularly on the right side of the tumor. But overall, it's a nice response. And it's also hoped that this is going to evolve over time until we get to the cross-sectional imaging. So these are our response rates. Again, these are blinded reads by 2 radiologists that read these in consensus. They provide M-resist reads, and they're completely blinded to the study group. When you look at the Y90 control group alone, this matches the literature quite nicely at these reported radiation levels. So split relatively evenly between stable disease, partial response, and complete response. Very different story when we add microbubbles with this. So Y90 plus UTMD, we only had 2 patients in the entire trial that had stable disease. More than half of the patients had an actual complete response, which was really, really impressive to see. And it took some time, but after we followed these patients all for at least 1 year, we also saw a statistically significant improvement in overall patient survival as well. So P equals 0.03, hazard ratio of 0.51. And this kind of reinforces our preclinical data in that not only are we improving the overall tumor response rates in these patients, but we're actually improving clinical outcomes as well. In conjunction with this trial, we also began to expand it into another area, specifically intrahepatic cholangiocarcinoma and other metastatic disease. These are, when it comes to ICC, this is really an aggressive epithelial tumor with poor prognosis and high morbidity. And outside primary liver cancers as well, the liver, of course, is a location for really one of the primary locations for metastatic disease, mainly due to its dual blood supply. So unfortunately, a lot of these patients present with relatively advanced disease, and local regional therapy is generally offered to about 70% of these patients who are ineligible for surgical resection, but not going on to full systemic therapy. So with this in mind, we developed NCT 05328167, very similar in that patients with either intrahepatic cholangiocarcinoma or metastatic disease to the liver provided informed consent. Only in this case, we obtained quantitative contrast-enhanced ultrasound the day of the flow study, which is generally 2 weeks prior to treatment. And then we did our very similar exams, UTMD, 1 to 4 hours post-treatment, 1 week post-treatment, and 2 weeks post-treatment. Very similar overall study design. What I'm showing you in yellow is kind of the major differences from the prior study. We did this with a volumetric probe to kind of get more homogeneous coverage across the entire tumor. The system was also modified to provide real-time display of ISPTA. We acquired volumetric imaging, which is interesting for some of the treatment response assessments. And because this is a slightly rare tumor, particularly at our institution, we compared to matched historical controls. One example of this, so this is a 61-year-old male patient, 4-centimeter ICC in segment 2-3. You can show it showing up very nicely in both the MR and PET. This is 2 hours post Y90 treatment. So here is the tumor on 2D V mode. This is just an example in contrast enhanced ultrasound just on 2D. And these are the examples of the 3D either destructive sequence, which is shown here on the left, or the replenishment sequences, which are shown here on the right. So you are essentially given 3 orthogonal volumes and then the rendered image on the bottom right. A little difficult to make this out, but you can kind of see this hypoenhancing mass where the intrahepatic cholangiocarcinoma is on the right. Same patient 1 week post-treatment. Again, still therapeutic levels of radiation present within the tumor. Not a lot you can actually really make out during the flash destruction sequence. But when you look on the right side during the reperfusion, you're beginning to see this less and less vascular area within the tumor. And at 2 weeks, this becomes even more pronounced now that you're able to see across the entire volume. There's very little residual enhancement within that tumor itself. And in this particular case, it matched up quite nicely with the contrast-enhanced MRI. This is the same case 2 months post-treatment, and you can see with the arrows here, we have this very nice avascular area completely responding a patient. So in terms of the final data set, as you can see, it was a relatively heterogeneous group. But what was nice to see is that there was no differences in physiologic monitoring pre and post bubble destruction, no statistically significant differences in lab values between groups, and no cases of radioembolization-induced liver disease. So very similar to our work in HCC, this was very well tolerated and really had an excellent safety profile. In terms of the final tumor response data, this is, again, consensus RECIST reads, mRECIST reads from 2 blinded radiologists. As I mentioned, these are very aggressive tumors, so the distribution across response rates is pretty wide. When you look at Y90 alone, we had 5 patients with progressive disease, 4 with stable disease, 2 with partial response, and 4 complete responders. Better when we combine microbubbles, still a lot of heterogeneity. Happy to report that we had no patients with progressive disease, but we still had 4 patients with stable disease. Although it was nice to see that half of these patients did have complete response. When we just focus on intrahepatic cholangiocarcinoma, it gets a little clearer. We kind of account for some of that heterogeneity. The Y90 itself has a relatively similar distribution, but when we look at the group that's just Y90 combined with ultrasound-triggered microbubble destruction, just in the cholangiocarcinoma patients, now we see that over half of those patients are actually having complete response. And you can see statistically we get a little bit better separation overall across the patients. So in conclusion, numerous clinical trials are now showing the promise and safety of combining microbubble cavitation with radiotherapy. At this point, we have randomized controlled data demonstrating improved tumor response and patient survival, which also mirrors a lot of our preclinical work. And the hope is that in future, this work is going to focus on multi-center trial expansion and also expansion into other radiotherapeutic applications. On that note, I just want to thank all of our collaborators. As you can imagine, this is very multidisciplinary work, our different funding sources, and thank you for the attention and the invitation to be here.
Thank you so much, Dr. Eisenbray. So we have, this is our Q&A. We realize we're a little bit tight on the time window here. Those of you that have some questions, please put those questions in the Q&A bar on your screen's lower menu so that the faculty can answer those questions readily.
Yes, the first question is for me. He wants me to elaborate on the limitations on the therapy and the benefit for using a more aggressive strategy, higher pressure, for example. Well, I start with the limitations. This is a proof of concept study that we have done. So at this point, we are using the actual echocardiography machine, and so we need a lot of staff, physicians, nurses in our ER. So, and that's obviously a big limitation. And in order to overcome that, we are betting on a small device to be used in the ambulance that can be managed by a paramedic, especially a non-imaging study. We have used the pulse length we use for the sonothrombolysis trial in acute myocardial infarction is about 4 microseconds. We used 20 microseconds pose in the beginning of the study in order to try to deliver higher energy to the myocardial infarction area. And Otto Kemp in the Netherlands observed some coronary vasospasm, so we stopped using it. However, that case I pointed out of pulmonary thrombosis, the kid had a big pulmonary artery thrombosis. I used that particular software with 20 microseconds, and that was very impressive because it opened very quickly the pulmonary artery because of the high energy. So I think there might be a room for especially bigger vessel thrombosis to use a higher energy ultrasound in order to treat those patients. But I think for small vessels, especially coronary in the coronary artery setting, vasospasm is a concern. So I think that at this point, results are pretty good, and probably in the beginning, I think the solution or any improvement will be seen when we combine lytic therapy with sonothrombolysis. That's my perception. So that's why we are so interested in that subgroup of patients we are treating that get previous lytic therapy.
Well, I mean, we can give a quick run. So the question
Yeah.
is, does it require a lot of extra bubbles to do this? And the answer is generally no. I know it can seem like that, but we, for example, for the sonoporation is doing infusion, and for John's radiosensitization as well. So these are not bubble concentrations or dosages that are way outside the clinical norm. These are not quite, at least in our case with the pancreatic study, not quite within the manufacturer's range, but it's not much bigger. So, and it fits the overall level. So I don't think there'll be a safety issue in that, and it's not as critical as it may sound.